Very good. All right, well, welcome everybody to our first webinar of 2024. I'm really excited to have Dr. Allison Nazinitsky with us, or Dr. Naz, as we like to call her. She has got some really fun cases to review today. We've known Dr. Naz for, I don't know, 3 or 4 years now. Been great to work with her. Patients love her, providers love her. It's just been a great relationship all around. So Dr. Naz, I will kick it off and hand it to you. And you can tell them a little bit about yourself and the things you have to talk about today.
All right. Well, thanks everybody for joining my webinar series. I titled this Case Potpourri because I'm going to go through 6 cases, maybe too fast, hopefully not fast, not too fast, so everybody can listen. But I just want to share my excitement for telemedicine, infectious disease, and the benefits and how much I've enjoyed this, and hopefully share that through the case series that I have in store for you. A little bit about myself and how I got into telemedicine, infectious disease. So I did my fellowship from 2013 to 2015 at Washington University in St. Louis. In 2017, I made a transition into travel infectious disease where I did locum tenens work, traveled all over the country. I then got into telemedicine through that. With all my state licenses, it made it easier to get into telemedicine. I have worked in over 50 hospitals with more than 10 EMRs. I lost count after all the hospitals I have on my CV. I do have 16 state licenses. And my favorite part of telemedicine is that I get to be part of the team all across the country, and I get to see the best of every part of healthcare and also the worst, but mostly the best. And I get to take the best of every network and every hospital and get to share that with the other hospitals that I'm covering. And I get to work with every part of the healthcare team. So hospitalists, primary care doctors, pharmacists, nurses, all the microbiology labs that we work with. And then of course, our telemedicine team. It's just been such a great team, very collegial, and that's the most, and then obviously the patients too. But and then everybody likes to ask me, what's my typical day like? And I really don't have a typical day. It depends on which hospitals I'm covering and in what capacity. But I would say on average, it's anywhere from 1 to 30 plus patients a day, depending on which hospital that I'm covering. So a little bit about what is telemedicine infectious disease. So we have consults where I do synchronous consultations where there's a video cart, a nurse or a telepresenter will wheel me into the room. I get to talk to the patient, interview patient, put in my own notes, put in my own orders, and discuss with the referring physicians. And also some asynchronous consults. So I'm not a big fan of curbsides. I really like to read about the patient, have all the information at hand. So an interprofessional consult, I can look through the chart, put in a note, and then discuss with the referring hospital. And even though I'm not directly involved with the patient, I'm able to give really high-level recommendations for that patient. I do mostly inpatient, but there's sometimes some outpatient questions that come about. I also do telemedicine stewardship. So I work with MD Stewardship to join the meeting to provide stewardship across the country. And the most common diagnoses, there's a lot of them, but cellulitis, osteomyelitis, diabetic foot infections, prosthetic joint infections, meningitis, bloodstream infections, including endocarditis, complicated pneumonias like empyemas or parapneumotic effusions, complicated UTIs, abdominal abscesses like perforated diverticulitis cases, multi-drug resistant infections, and then patients with multiple drug allergies where we're limited in what we can use. Really, what I like is to be able to keep patients local, reducing the patient transfers, decreasing readmission and decreasing length of stay and mortality, decreasing hospital-acquired infections, and then reducing antibiotic use, which overall decrease costs, toxicities, and then just improving the quality and improving patient safety all across the country. There are certain diagnoses like Staph aureus bacteremia, where it's been proven to have an ID consult has improved mortality, and being able to offer that across the country where there's no infectious disease doctors is really important to me to be able to provide that care. So this is a map of the United States, and in the white is where there's no ID physicians at all. So they say 80% of counties in the United States, and you can see the Midwest really is the predominant of this area that's white, does not have access to infectious disease specialists. So being able to cover not only the tertiary care centers, but a lot of the rural hospitals is really important to me to be able to provide expertise to these patients. And then the shortage is really not going to get any better anytime soon. So this is the match results from 2024. And as you can see, only 303 fellows matched this year. There probably will be more after the match, but pretty low numbers. It ends up being about 6 ID doctors per state. But some of the bigger states like Massachusetts and New York and California, they might have 15 or 20 that end up staying there. So really leaves very few ID physicians for the rest of the country, especially rural healthcare. And so out of the country, these are the states that I cover the most in. So all over, I get to see East Coast and West Coast and South, all over. And then in Nebraska, these are the cities I get to cover with tele-ID through various modalities. So just trying to show a breadth of how many hospital systems I'm involved with. So I want to get started with some cases here. So this is case 1. This is a 35-year-old female. She presented to a critical access hospital with headache, fever, confusion, and altered mental status. And her history was that she recently went hiking in Colorado Springs 3 weeks prior. So headache and fever, we always get concerned for meningitis. So that's the route that they went down in the ER. And this is a critical access hospital that does not have tele-ID. So I actually got called as I was covering a tertiary care center that they were considering transferring this patient, and they wanted to run the case by an ID doctor before they transferred her. So they did a lumbar puncture at this hospital before transfer. She had 286 nucleated cells, 68% lymphocytes, and 22% neutrophils, and then an elevated protein. So an aseptic meningitis picture. They had some rapid diagnostics at this hospital, which is good. Some of the smaller hospitals don't have in-house testing, but their rapid PCR panel was negative, and then they were able to get a gram stain back. And it was had 4+ white blood cells, but no organisms seen. She did have a CT scan of her brain, which was negative for any acute findings. And then this came back after she was even discharged, but it just showed mature lymphocytes and no evidence of malignancy. So meningitis is especially aseptic meningitis is a good diagnosis that can be kept local. Oftentimes physicians and patients really get worried, even if there's more than 10 cells in the CSF, it pretty much automatically results into an ID consult to see what's going on. So in some of these cases, like aseptic meningitis, it allows patients to be kept locally, because sometimes if we can do an expedited workup and manage them locally, they don't need to be transferred, especially if there's no complicating factors. So when I get called from an outside hospital, or when I'm first assessing a patient with meningitis over the phone, the first thing I ask, are they having seizures? Do they have signs of hydrocephalus? Have they had recent mastoiditis or ear surgery? Do they have poor dentition, where we're thinking their teeth have possibly eroded into their CNS? Do they have genital lesions? Do they have a diffuse body rash? Things like syphilis can have rashes involved, or some of the mosquito-borne or tick-borne illnesses. So I always ask these questions before, to make sure we're doing everything we can for these patients. And if they don't have these complicating factors, no seizures, no need for an EEG, really they can be kept locally, and we can do tele-neuro consults also in the local hospital. So rapid diagnostics are very helpful, but sometimes limited in some of the smaller hospitals. Getting a CT scan to rule out hydrocephalus or mastoiditis or some of these complicating factors, and then always getting the basics on your CSF, including an opening pressure. So this lady ended up having West Nile virus and meningitis. Her CSF IgM was positive and her serum IgM was positive. And she was transferred, so I saw her upon transfer, and the diagnosis was fairly clear just based on her history, and she had already started feeling better. So we gave her symptomatic treatment with analgesia and some fluids and stopped all of her antibiotics, and then she felt better and we sent her home. But we definitely could have kept her locally with just tele-ID. And I know her and her husband were very comfortable being transferred, but definitely could have given her the same level of care at her local hospital. So this is case number 2. This is a 45-year-old female. She has a history of hypothyroidism. She has a history of recurrent MRSA boils, and she presents to an outside hospital. This is actually over the state lines of where where I was practicing, with shortness of breath, fever, and cough. And she was initially treated with steroids and sent home. She had worsening hypoxia and came back to the ER and had some antibiotics and a CT chest. And basically they thought it was a viral illness because her husband and her son were also sick at the same time. They were all having the same symptoms. So she was just given more prednisone and sent home. And then the next day, she came back and now was hypoxic down to the 70s. Her labs were her white count was a little bit elevated, but of note, her liver enzymes were very elevated. And then she was transferred for pulmonary and infectious disease consultations. So I was not involved with the transfer process. I was covering a tertiary care center this day, and I was called directly from the pulmonologist and the hospitalist to give me a heads up. Hey, this lady's very sick. We are very concerned about her. Can you see her right away when she gets admitted? And so this was her initial chest x-ray. So she had moderate diffuse pulmonary opacities seen with pneumonia, edema, or ARDS. And upon transfer, so they had already gotten some history from her before I even saw her. So she works as a nurse and she lives on a farm, and her family recently cleaned out her barn. Very interesting. And this is her CT. So she's got these diffuse ground glass and reticular nodular opacities, and this is throughout her whole lung. She's very sick. She's on BiPAP on admission. And so at this point, the differential is this viral because she's got multiple sick contacts, bacterial, fungal. Could this be non-infectious inhalational pneumonitis? But her barn exposure, I think we were all concerned for histo was our biggest working diagnosis. And I can't take credit for that diagnosis. I remember the pulmonologist calling and saying, I think this is histo. But so right when I saw her, I was able to be wheeled into the room on the cart and talk to her and her family. And I said, look, we're all concerned that this is a fungal infection. I think we need to start this medicine called ambisome. And there's a lot of toxicities with ambisome. And we don't just give it out like any antibiotic. It's a very serious antibiotic. And so I counseled them and I said, let's start you on ambisome. Let's get a workup going, but we need to start treatment as soon as possible. Very, very sick, on the verge of intubation. They were able to do a bronch without putting her on the vent. And her pneumonia lower respiratory PCR was only positive for coronavirus, but this was not COVID. This was just one of the other coronaviruses. And then over the next 4 days, with steroids, some antibiotics, and ambisome, we were able to wean her down to 2 liters. And then by hospital day 4, we actually got a diagnosis. So I kind of gave it away in the beginning, but this lady was immunocompetent, had no HIV, was not on any sort of TNF inhibitor, no chronic steroids, very immunocompetent with primary acute disseminated histo. So this is pretty rare. And so her bronch ended up growing histo, and then her serum and urine galactomannins were off the chart positive. And so this is the other part to this, is that by hospital day 6, she was off of oxygen and she was able to be discharged home to continue her home infusions. And this was across state lines. This was all coordinated with the ID docs there and the case managers. And then she was then transitioned to itraconazole, and she's doing well. And I would say this is a world record hospitalization for how quickly someone got better with how sick they were. And it was because of the team efforts between, well, not just myself, but the pulmonologist, and really the communication that went on between the hospitalist, pulmonary, and then the referring hospital, and then telling me exactly what I needed to know, that everybody was concerned for this, fungal process, which sometimes doesn't come to light for a couple of days in the hospital, but everybody had talked to the family and gotten this history. So I wanted to share that case because of those reasons. So this is the third case. This is a 60-year-old male with methamphetamine use, and he smokes methamphetamines. He has very poor dentition, and he presents to a tertiary care center, regional referral center, with altered mental status, headache, and fever and confusion. So kind of along the same lines as the first case, we get a lot of calls for possible meningitis or CNS infections. His initial white count was 17, hemoglobin 9.9. His chest x-ray showed a small infiltrate in the left upper lobe. And he was really sick. So he got intubated in the ER. He got a CT of the chest. This shows a nodule in that left upper lobe. So it's more of a nodule than like a focal infiltrate. And then they did do a CT of the head. And then this is his MRI. So he's got 2 areas of abscess in the right parietal and temporal lobe, and then the medial left occipital lobe. So pretty extensive. And I don't know why it says case 2, but very extensive amount of cerebral edema. You can see midline shift. And fortunately, this hospital has neurosurgery present. So in the ER, patient underwent a emergent left frontal ventriculostomy and had in his spinal fluid almost 58,000 white cells, and of those 64% were neutrophils, and his protein was greater than 600. And then his gram stain was negative for any organisms, many PMNs. And then he underwent an emergent right posterior temporal parietal craniotomy and had resection of this brain abscess. And then this is from the lab. So he had gram positive rods on his gram stain. He was intubated with a ventriculostomy drain in the ICU for a few days. He had the heavy growth of these gram positive rods. And then we got pathology back pretty soon because they were initially concerned about cancer. So we got marked acute inflammation with some tissue destruction, and then gram-positive branching filamentous organisms suspicious for nocardia. And so anytime we get this gram-positive branching filamentous organisms, we call these BFOs in ID, and all ID doctors get really excited for BFOs. And so we're, I was like, oh, this is so exciting. And so this patient was already on broad spectrum antibiotics. And then I was able to work with the lab at this hospital to get all of his specimens sent out to reference labs and make sure that they were going to get full identifications and susceptibilities, because right now we didn't have a good idea of what was causing this. Could this be nocardia? Could this be something else? And so I initially had him on broad spectrum antibiotics covering the typical organisms we see in brain abscess. But after the nocardia came back as possible nocardia, I adjusted his antibiotics to ones that cover more nocardia coverage, and was able to work with the pharmacy to order in some of these other agents. So his brain abscess ended up growing 2 different organisms, a biotrophia and a granulocatella. And then his CSF ended up growing nocardia. So very interesting case. He's still in the hospital, and he's in acute rehab right now, and I'm still awaiting the susceptibilities for these organisms. But he's doing very well, and I have him still on broad spectrum antibiotics, and I've ran this case by several other folks. This patient had 2 negative HIV tests. He's never been on any medications. So assumingly he's immunocompromised from probably extensive meth use, but very interesting case. So nutritionally variant strep are these species, A. biotrophia and granulocatella. They're part of the normal flora of human respiratory tract, so probably from his poor dentition. And they're very difficult to culture in the lab. So they can look all different shapes and look pleomorphic. They can be gram positive, gram variable, and so difficult to identify, and also difficult to gram stain and get a characterization. And then nocardia, these are gram-positive aerobic actinomycetes, and they can cause localized or systemic infection and can disseminate to the CNS. 1/3 are non-immunocompromised, and then they can relapse despite appropriate therapy. And there's 54 strains that can cause disease in human. And of those, 14% are the same strain that was isolated in our patient. So he's doing well. And I wanted to highlight this case first off because it was very complicated with working with the lab and adjusting the antibiotics covering these organisms. But also this patient was pretty, he doesn't have a lot of resources, and he had family at his bedside, at least 4 to 5 family members every day that I saw him. And they would never have been able to travel 3 hours away to the nearest center with an infectious disease doctor. So the fact that they were able to keep him local was just great for the family too, to get him through this, because they were at his bedside every day until he was, well, they're still at his bedside because he's still in the hospital. But I think that was one of the most important parts too for this case, from this case to highlight, is that there was just no way that this family would have been able to travel to see him without having tele-ID being able to be by his side, and having families support these patients and their loved ones is really one of the most important parts of getting patients better. So this is my fourth case. This is a 62-year-old male, has history of diabetes, hypertension, chronic kidney disease, peripheral vascular disease, and a right foot ulcer, was following with podiatry for 3 months. And he presented to a clinic at a critical access hospital with worsening pain in his right foot and cellulitis. The photo on the left was an outpatient photo from his podiatry clinic. And then the photo on the right, the orange around it is part of his dressing. But if you can see, there's some purple, kind of darker, dusky looking hues in his arch of his foot. He has an interesting history. He's been on chronic suppressive doxy for some sort of broad chronic infection, but we didn't have much history on that. It had been 20 years ago. In clinic, his blood pressure was low, 88/60. And then they had checked labs. His white count was up to 18 and his creatinine was up to 2.06 from his baseline of 1.4. So as I was called, they had already ordered a foot film, and then it hadn't been read until I was about to go see him. And I saw him probably within 30 minutes of being called. And so they are reading some gas in the tissue of this foot. And so once that came back, as I was talking to him, I ordered a stat tib fib film to kind of see how extensive the gas was in up his leg. And so they were doing the film as I was interviewing the patient. And so I was talking to the patient, and he's this very, very stoic man. He doesn't want to be in the hospital. He's upset that he's even admitted right now. And then I'm telling him, hey, can you stand up, bear weight on your foot? Let me see how you can walk on it, because I just saw this gas, the gas had just come back, and he couldn't bear any weight on his right foot. And I tried to reiterate, can you normally bear weight on your foot? And he says, yes. And somebody that has chronic neuropathy in their foot to now not be able to bear weight is, very much pain out of proportion. So in ID, pain out of proportion, necrotizing infection, they go hand in hand. So this patient had definite pain out of proportion, even though he's stoic sitting there, I want to go home. So this was actually a CT scan after transfer. You can see all the black in here is all gas in his tissue. So from the foot up through below the knee. And once we started him on broad spectrum antibiotics, but we definitely transferred him immediately for surgical care. And this all happened really quickly. So we kept him NPO. I was able to communicate with the infectious disease doctor that was going to be seeing him at the tertiary care center. We got a hold of the admitting hospitalist team and and the surgeon. So everything was streamlined, and he actually went straight to the operating room at that point, and had, necrotic tissue and muscles in the deep posterior compartment. His blood cultures remained negative. He ended up growing strep anginosus and group B strep. But I wanted to highlight this case because it's a sort of a bread and butter diagnosis that we see, but dealing with pain out of proportion, and then helping with the transfer process, because I also cover at this tertiary care center. We were able to work as a team, the primary care doctor, myself, and the admitting team, to get this patient expedited treatment as if he presented to the ER there. It was a seamless transition of care, which oftentimes in our healthcare system, there's a lot of fragmented breakdowns of care. But this allowed for really streamlined, expedited management of this patient. So okay, this is my fifth case. I'm going pretty fast here, but I wanted to get through a lot of cases. 79-year-old female. She has a history of squamous cell carcinoma of the vulva. She had a hemivulvectomy and radiation a year prior, and she's coming into a critical access hospital ER with left-sided chest pain that woke her from sleep. She had associated cough that made the chest pain worse. And then her only real other medical history is that she had recurrent MRSA boils and abscesses and had multiple INDs. In the ER, she was very stable. Vitals wise, and her labs were pretty unremarkable. Her procalcitonin was negative, and her D-dimer was elevated. Her viral testing was negative. And this was her chest x-ray, which was read as normal. And then this is her CT chest. So they did a CT chest mostly because of her elevated D-dimer, and shows bilateral cavitary lung lesions with a differential including septic pulmonary emboli, and then atypical infection and metastatic lesions. So anytime any image is read with a cavitary lung lesion or septic pulmonary emboli, that's pretty much an automatic ID consult. I think everybody's always calling us for, oh, they have a cavitary lung lesion or septic pulmonary emboli. So this is a very, very common call that we get. This lady did not want to be admitted either. And they were going to possibly transfer her actually to the tertiary care center from the ER, but she was very stable. And so I got consulted and Telepalm got consulted on her, and we were able to see her and assess her at the critical access hospital. So we got blood cultures, sputum cultures, echo. She remained afebrile, very stable. I had very low suspicion for bacteremia, even with her MRSA history. So we got every test ordered and in the lab, and then she actually went home the next day. I did place her on doxycycline and Augmentin empirically pending all these cultures. And then pulmonary was able to arrange her an outpatient IR biopsy 4 days after discharge. So that's really quick, which was awesome for her. And she was very happy. Her and her family really did not want to be admitted. They wanted to do an outpatient workup. And then unfortunately, it did show squamous cell carcinoma. But this was a success because first off, she didn't want to be in the hospital, and we were able to do all of this as an outpatient. So we reduced her exposure to the hospitals, and we're able to keep her at home throughout, this process instead of being out of town and at a different hospital throughout the workup. So this is my last case. This is an 81-year-old female. She has hypertension, AFib, recurrent UTIs, and she has a history of recurrent C. diff. She had 6 episodes, and she even had a fecal transplant in 2020, which put her into a remission. So she had not had any episodes of C. diff since 2020's fecal transplant. And she comes into the critical access hospital ER with sepsis, altered mental status, and diarrhea. She had recently been treated for a URI with azithromycin, and anytime she goes on antibiotics, she's placed on oral vancomycin, and then they continue it 5 days after completion. And this was just her primary care doctor and I guess her previous ID doctor from 2020 that had made this recommendation. So after she completed the PO vanc, is now when she's presenting with altered mental status and diarrhea. But one day after she completed the vancomycin, I'm sorry if that's confusing. I tried to make this as clear as possible. But one day after she completed the vanc, she actually started having diarrhea. So she was so worried. So she came to the ER and had negative C. diff testing. In the ER this time, she had a UA with 10 to 14 white cells. There were some squamous epithelial cells. And this time her C. diff testing is positive, toxin, antigen, and PCR positive, like true C. diff positive, which normally in the guidelines, you don't repeat C. diff testing if they've done one within 7 days. But it was, she's having profuse diarrhea, over 10 bowel movements, really loose diarrhea. So her family was very nervous about her having C. diff and being at a smaller hospital. And so they were really pushing for getting her transferred for ID consults. And then they really wanted her to have another fecal transplant. And then she had been started on ceftriaxone for UTI, and her family was worried that her altered mental status was actually from a UTI this time. And they've been very educated about not being on antibiotics for asymptomatic bacteria. So they really wanted her on the ceftriaxone too. So they were very involved with this patient's care. But her hospital course, I stopped her ceftriaxone. She's having 10 bowel movements a day, had no symptoms of any sort of urinary dysuria. So I just said, we got to stop the ceftriaxone, continue to run oral vancomycin. And I didn't do fidaxomicin because of her prescription coverage. And then we ended up doing a CT, showed pancolitis, and then she continued to improve on oral vancomycin. And then this is, we were able to arrange for her to have bezotoxumab, which is a monoclonal antibody against C. diff, which, surprisingly, she had never gotten any doses of this, even though she's very high risk for relapse. So we were able to arrange for her to get a monoclonal antibody while she was still on the vancomycin. And then they had never done a fecal transplant at this hospital, but I was able to arrange for her to have a fecal transplant at this critical access hospital 24 hours after her last dose of vancomycin. And once I described the way we were going to do this, the family was so happy that she didn't need transferred. She's 81, pretty frail, and they were so happy that all of this could be done locally. And so that was the summary of that story, is just how we were able to do some very complicated treatment at this smaller hospital and also provide the reassurance the family needed. So in summary, patients can be kept locally for ID expertise with tele-ID. I do believe it enhances the patient's perceptions of the local hospital to be able to offer these services. Consulting at these critical access hospitals can help expedite a workup, can streamline the transfer process, and even streamline the discharge planning process. We can keep things within the same system and follow-up testing locally so that the patients don't have to travel an hour or two away for things like CT scans, MRIs, infusions, and even fecal transplants. And then tele-ID is beneficial also at the tertiary and regional referral centers because of the shortage of ID doctors covering weekends, covering vacations. That we can help on all these complications where, you know, the hospitalists or surgeons may not feel comfortable managing. So I'll just open it up for questions now.
Yeah.
Thank you, everybody, for joining.
Well, thank you, Dr. Nez. Those were fascinating cases. First question I have on the patient that had the necrotic tissue in his foot and the gas in the leg, were like Dopplers done locally, and could the nursing staff feel a pulse in that leg?
So he did have a pulse. It was diminished, but he did have a pulse. So there wasn't like acute limb ischemia on top of everything. But he did have a pulse.
On the C. diff case, is that a normal course, preventive course, like when someone goes on antibiotics to do like Vanco as kind of a backup, or is that a little outside normal?
So it hasn't been studied to prevent C. diff in somebody that's got recurrent C. diff. It's sort of a expert opinion, and a lot of doctors will put patients on prophylactic vancomycin while they're on antibiotics. Yes.
Okay, cool. All right. Just a comment, just such a huge advantage to have the services for patients. We've seen patients transfer as far as 6 hours away sometimes for osteomyelitis, and it's just a huge benefit to help those folks stay close to home, close to family, close to their support system. It's, it is really an amazing service, especially for critical access hospitals and for hospital, like you said, those regional hospitals where maybe they don't have 24/7, 365 ID support. So, do we have any other questions? Rachel says everyone should have tele ID.
Thank you. I agree. Everyone needs tele ID.
Yes. Yes. Well, very good. This has been fascinating stuff. I think of you as a detective, looking at all the clues and putting the clues together in order to try to come up with a diagnosis. And it's pretty fascinating work, and we're glad to have you partner with us.
Yes. It's great just being part of the team. And like I said, all the hospitalists that call me and surgeons call me, and it's really collegial, and really the patients at the foremost front of our decision making and discussion. So I think that's just everything I went into medicine for. So
yeah, very, very good. Well, thank you everyone for joining us. This will be posted later on the Teledyne website. So if you want to watch it again or go back and review some of these cases, I'm sure that everybody could benefit from walking through them again, because you put everything together really nicely.
Thank you. Thank you.
All right. Well, thank you, everybody. I'm going to stop recording, and we will see you in April. We're going to do a series of or a discussion on telehospitalist and review some cases again. I think we've got some interesting ones there. So looking forward to that. Thank you, Dr. Naz. Thank you, everybody, for joining.
Thank you.
Thanks.